Welcome to Med One Benja. My name is Benjamin, and today I'm going to talk about adrenal conditions. And specifically, we're going to look at the adrenal cortex, and we are going to see first the conditions where the adrenal gland is hyperactive, the cortex. So I named this the hypercortex. So just to remind you a little bit about the basics of the adrenal gland and adrenal hormones, we have the zones of the adrenal cortex. That's the zona glomerulosa, fasciculata, and reticularis. And the zona glomerulosa mainly produces aldosterone, and aldosterone is going to depend on the renin-angiotensin aldosterone system. Then we have the zona fasciculata, the ones that produces cortisol, or the glucocorticoids, and that one is ACTH dependent. We have the zona reticularis that produces the dihydroepiandrosterone and the androgens. And then we have some conditions where we have loss of function. And when we have loss of functions, we shall have things like hyperpigmentation due to increased POMC and ACTH. And we have things like cortisol function. When we have high cortisol, we have increased gluconeogenesis, increased blood pressure, immunosuppression, and things like that. So basically, throughout this series about adrenal conditions, we are going to look at different things that are related to these hormones. And mainly, as I told you in this video, we're going to cover the hypercortex, or the increased hormone production from the cortex. So first, I'm going to start with the primary hyperaldosteronism. As we have seen, the aldosterone is produced by the zona glomerulosa. So we have the major causes of primary hyperaldosteronism, what we call Conn syndrome. And these are going to include an aldosterone producing adenoma. This is a benign tumor of the adrenal gland that is producing the aldosterone. Then we have bilateral adrenal hyperplasia, which is basically when we have an increased size of these glands. Then we have sometimes, rarely, where we have a carcinoma or cancer of the adrenal gland. And this is going to be a one that produces this aldosterone. So in aldosterone is mainly whenever we have decreased salt or decreased volume in the body, in the juxtaglomerular cells, and or the kidney tends to detect that the perfusion is low. And when the perfusion is low, we are going to have production of renin. Now, renin is the enzyme, and renin is going to go to angiotensinogen, which is the inactive form that is stored in the body, and cleave it to produce angiotensin 1. Then the angiotensin 1 is going to be converted to angiotensin 2 by the S, which is the angiotensin converting enzyme, which is produced by the lungs. So when we have conversion of this to angiotensin 2 has very many effects. It is a potent vasoconstrictor, and it is also the one that's going to go to the adrenal and cause the release of this aldosterone, which aldosterone will go and work on the renal tubules and increase on the reabsorption of sodium, excretion of potassium. And when we reabsorb the sodium, the volume is going to increase. So basically, that is what's supposed to happen. So most of the times, these patients who have primary hyperaldosteronism are going to have resistant hypertension. These are patients who are going to start on different drugs, and they'll still continue to have the BPs staying up, and they may be having features of hypokalemia. Though it is not uncommon that many patients who have hyperaldosteronism are found to have actually a normokalemia, or a normal amount of potassium. So they can have things like metabolic acidosis, they can have things like mild hypernatremia because of this increased aldosterone, and then they have a low renin. This means that the aldosterone is not coming from the normal cascade, because remember, renin has to go high, and when renin is high, that is when you have its cascade going on to producing the aldosterone. So most of the time when we are having a patient with hypokalemia of less than 3 or less than 3.2 if they're on diuretics despite replacement, they may want to suspect that they're probably having this primary hyperaldosteronism. So the investigations we do is start with the screening, where you do the aldosterone and renin ratio, and when the ratio is above 1 to 25, 1 to 20, some books say 1 to 20 to 30, we are going to conclude that maybe we have a primary hyperaldosteronism. And sometimes we have false positives, especially when we have patients with CKD. Then we have the confirmatory tests. Now, after screening, after doing the aldosterone-renin ratio, you want to confirm, does this patient really have primary hyperaldosteronism? And the first test we do is the saline suppression test. where we can give a patient 2 liters of normal saline for about 3 days. They're going to receive this in supine position, and they're going to have been previously on a low sodium diet. Or if it is known that you want to do what we call the oral salt loading, where for 5 days you give a patient a high sodium diet, and then you measure the plasma aldosterone afterwards. And if it is less than 5 nanograms per deciliter, because if we have been giving someone salt, a lot of salt, we expect that they have a lot of sodium in the body, and therefore the aldosterone is going to go low. So if it remains high, if it goes less than 5, then we know that we are okay. Or if the 24-hour urinary, the one we collect for a whole day, the 24-hour urinary amount of aldosterone is less than 14, then we know that this patient does not have a primary aldosterone. But if it remains high, then you know the patient is having primary hyperaldosteronism. Then we have on imaging, after you have actually confirmed that this patient now cannot be saline suppressed, or they really do have primary aldosteronism. The next step in management is that you want to localize. You want to find out, is it both adrenal glands producing the aldosterone, or we have just an adenoma, because each of these is going to give a different management. If it's both, most of the time we don't do surgical management, but if it's an adenoma in one of the adrenal glands, then this patient is candidate for surgery depending on other things. So when we're doing the imaging, you want to do a CT scan, and this is going to be the conventional ones, because we're going to do 0.5 centimeter cuts, because this adrenal adenoma sometimes are small. So if you do the 1 centimeter cuts, you may actually miss out on this tumor. So we do the 0.5 centimeter cuts to localize, and if we see the tumor, then we can decide, do we go on to do surgery or not. Then we have adrenal vein sampling. Remember, the adrenals are drained by a single vein, though supplied by 3 arteries. We have an artery from the aorta, an artery from the phrenic artery, and an artery coming from the renal artery. So we can, by cannulating the adrenal vein, you can be able to measure the cortisol as well as the aldosterone coming from those veins. And when we find that one side is has a 4 times greater ratio than the one on the other side, let me say the right is 4 times, when you do the cortisol aldosterone ratio on one side is 4 times or more greater than the one on the other side, then you can conclude that this side that has the higher ratio is the one that is having the adenoma. Then we have the scintigraphy, where you can do with the 16 beta iodomethyl cholesterol, because remember, the adrenal gland takes up cholesterol to use it to synthesize these hormones. So this iodomethyl, unlike normal cholesterol, is going to stay within the gland, and when you do the scintigraphy, when you do the imaging, you're going to be able to see it as a hot nodule. So the adenoma is going to be a hot nodule, like the same test that is done in thyroid conditions, but just we use different compounds. Then management, medical management is going to be first line for both patients, where you want to put down that BP, and you want to use spironolactone, which is a aldosterone receptor blocker, and you want to supplement the potassium if it is low. Then if it's a unilateral adenoma that is producing the aldosterone, you want to go ahead and do adrenalectomy. And if it's bilateral or hyperplasia, you want to just continue the medical management with spironolactone, eplerenone, and then manage other things. Then the next one is the Cushing syndrome, and this one is very common and commonly talked about, and I'm not going to cover a lot about it. I'm not going to cover the clinical features too much. I'm going to concentrate on the tricky bits of it. So when we have Cushing's disease, you want to know, we have Cushing syndrome and we have Cushing's disease. Cushing disease is when we have a pituitary adenoma that is producing adrenocorticotropic hormone that commands the adrenals to produce a lot of cortisol. Then we have Cushing syndrome, where the hormone is not, the ACTH is, or whatever is causing the cortisol to be high is not coming from the pituitary gland. So we have the causes of Cushing syndrome are going to be ACTH dependent. These ones are coming from production of ACTH, and ACTH can be from the pituitary, that is in Cushing's disease, or it can be ectopic coming from elsewhere, that is in, for example, in small cell lung cancer, when we have carcinoid syndrome or carcinoid tumors in the foregut. It can be ACTH independent, whereby ACTH is not involved at all. This means it is primarily in the adrenal gland. We are having the adrenal producing a lot of this cortisol on its own, we have what we call the primary pigmented nodular adrenocortical disease. And netly, these patients, you'll find that they have these small black adrenal nodules that are less than 5 millimeters. So they are, and most of the time they're associated with what we call the Conn complex, which is a whole other thing which you can look up or check somewhere and read about it. Then we have exogenous steroids. This is most common. You find someone has been taking steroids for maybe for a medical condition or abuse. And then we have the pseudo Cushing's disease, which is very important because these are patients who have things like depression, things who are alcoholism, people who are pregnant, chronic renal failure, and stress, and they kind of have elevated levels of cortisol. Most of the time, when you treat these underlying conditions, they're able to return to their baseline. So the clinical features of high cortisol are going to be the central obesity, the moon face, the buffalo hump, the purple striae, the thin skin or bruising, foxmal myopathy, hypertension, diabetes, mood changes, psychosis, osteoporosis, as well as infections, because the cortisol is found to lower the immunity. So investigations we are going to first start with the 1 milligram overnight dexamethasone suppression test. And when we fail to suppress, we now suspect, because when we are dealing with someone who suspect to have this, you want to first find out, do they really have the disease? Then after you have diagnosed, you want to now start localizing. Is it coming from the pituitary? Is it not coming from the pituitary? It's coming from, is it ACTH dependent or not? If it's ACTH dependent, is it coming from the pituitary gland itself or it's an ectopic source? So after doing this 1 milligram dexamethasone night test where you give the dexamethasone at 11 p.m. in the night and then you measure the cortisol at 8, normally the patient is going to have, a normal person is going to have less than 3 micrograms per deciliter of cortisol. But then, if they are having a higher than this, then most of the time, we may conclude that we cannot suppress and therefore they are having Cushing's disease. And if you get it negative, but still you have a high index of suspicion, you can go ahead and do the 0.5 milligrams every 8 hours, every 6 hours, and make sure you make 8 doses. So 0.5 and times 8 is going to be around 4 milligrams. We're given over 8 doses 6 hourly. Then you can do 2 milligrams over 48 hours. And this, all you're doing, you want to suppress the cortisol. If you fail to suppress the cortisol, then you know you're dealing with hypercortisolism. Then you can do the 24-hour urinary free cortisol and see if it is high, because these patients kind of have this increased production. So it's going to be obviously high. We have the late night salivary cortisol, because we know at night, most of the time, cortisol starts increasing in the morning and it's going to be highest in the morning, then it's going to start decreasing. And by late evening, it's going to be really, really at its lowest peaks. So when you do the 24-hour day late night salivary cortisol is supposed to be low, but you find that it is high in these patients. Then we can localize now that we confirm that we have Cushing's disease or we have hypercortisolism. We want to see, is it Cushing's disease? Is it not? So we check for the ACTH level. If the ACTH in the blood is low, then you know that this is ACTH independent. So it is an adrenal cause. It's primarily a tumor in the adrenal that is producing. If the ACTH is high, then you find out, is the ACTH coming from the pituitary gland or it's an ectopic source? So normally if the ACTH is between 15 to 500 picograms, in suspects is from the pituitary. But if it's greater than 1000, then most of the time this ACTH is coming from an ectopic source. That is a small cell lung cancer. Think about a bronchoadenoma. Think about things like carcinoid syndrome. Then we want to do further tests like the high dose dexamethasone suppression test. These are other tests that can be done. And for the high dose dexamethasone suppression test, you're going to give 2 milligrams every 6 hours for 2 days. And most of the time, what you want to do, you're suppressing with a high dose. So if it's a pituitary tumor, it's going to suppress more than 50%. But if it's an ectopic source, it is not going to suppress the amount of cortisol or of ACTH to less than 50%. Then we have the corticotropin releasing hormone test, and this one is where you give this. And if it's a pituitary, of course, the pituitary responds to the corticotropin releasing hormone from the hypothalamus. So if it is a pituitary source, it will just increase. If it's ectopic, it will still be resistant. Then you can do an MRI of the pituitary and you can do a CT of the adrenals. We have what we call the spectrosynous sampling, where we get 2 cannulas, one in the peripheral, like on the hand, and the other on the jugular. And then you measure the gradient. You want to see how much ACTH is the difference between the SCTH in the periphery and the SCTH on the jugular. If it's from the pituitary, of course, it's coming from the head. The jugular is going to be high, so we have an SCTH gradient. If it's not present and we just have the same amount of SCTH both in the jugular and the periphery, then this is an ectopic source. Then the management, whenever it's a pituitary tumor, you want to do the transphenyidal surgery. Sometimes there is a irradiation of the pituitary gland, but this one is accompanied by very many issues. Sometimes the patients go ahead and have this loss of vision because of interruption of that optic chiasma that is always pressed on by the tumor. So as you do the irradiation, sometimes there's damage to that, and because of that, they introduce the stereotactics radiosurgery, which is also called the gamma knife, and this one is a more precise way of providing these radiations to the gland in a more controlled way. Then we have if it's an adrenal tumor, you want to do an adrenalectomy or remove the tumor. Then if it is an ectopic SCTH, you want to treat the source. For example, with those cancers, you want to manage those cancers. Then sometimes if we cannot resect the primary tumor producing the SCTH, we can go ahead and do what you call a bilateral palliative adrenalectomy, where you remove the adrenal glands so that you have this cessation of production of this. And sometimes the medications we can use like ketoconazole, metapyron, or lidosterate and mifepristone. Then sometimes these patients, not sometimes, these patients will lead pre and post-operative steroids, because if someone has a adenoma and it's this side and it's producing a lot of SCTH, a lot of cortisol, the one on the contrast side is going to be suppressed. So if you just go on and do surgery without giving steroids pre and post-operatively, the patient is going to go into an Addisonian crisis. Then sometimes these patients may require steroids for life, even when they have the other adrenal gland intact, or sometimes for some time, where you do the SCTH stimulation test, where you give them SCTH and see if they can increase their cortisol production. If they can't, then you need to always continue replacing then if you do, of course, a bilateral adrenalectomy, you have to make sure that you replace also the mineralocorticoids, that is fludrocortisone. Then we have the sex steroid excess, and this one is when we have the production of these sex steroids from the adrenal. And most of the time, if it's estrogen, it can be estrogen, it can be androgen. So if it is a virilizing tumor, that is, if the tumor is leading to production of the androgens, that is dihydroepiandrosterone, we're going to mostly see this in women easily. In men, it may be subtle and may have a late presentation. So in women, you may see things like hirsutism, amenorrhea, infertility, a deepening of the voice, increased muscle mass, and temporal baldness. While in men, it may be subtle and calm to present later, but if it's a child, the child may experience rapid growth, early pubic and facial hair appearance. They may get acne, genital enlargement, and also a deep voice. And so often, these tumors may secrete also the glucocorticoids, so you look out the Cushingoid features. Then in feminizing tumors are tumors that are producing estrogen, and for men, most of the time they'll get gynecomastia, impotence, and testicular atrophy, while women, they may have irregular menses, dysfunctional uterine bleeding, postmenopausal bleeding. And for girls, you may see things like precocious puberty, that is breast enlargement, and early menarche, where they start their periods earlier than their counterparts. So the diagnosis you're going to basically measure for these hormones, you want to measure the dihydroepiandrosterone, and if it's urine, you want to measure the urinary 17-ketosteroids. These are products of breakdown of these androgens. The feminizing tumors, you want to check for the estrogen. The treatment is going to be adrenalectomy, and sometimes you have to check for malignancy, because the adrenocorticoid tumor, as we are going to see down, is one of the things that may cause virilization. So you may need to check for features of malignancy like invasion, recurrence, and metastasis. And if when you have metastasis, you're going to see sometimes you manage with drugs like mitoten, aminoglutathione, and ketoconazole. Then we have congenital adrenal hyperplasia, and this one is going to occur basically because we are having a disruption in the feedback to SCTH. So whenever we have SCTH is trophic, or it causes the growth of the adrenal gland. So whenever we have SCTH being produced, the gland is going to grow. So what happens in congenital adrenal hyperplasia is that we have a deficiency of a certain enzyme, and the most common enzyme is 21-hydroxylase hormone enzyme deficiency. And when we don't have this one, which can be partial or which can be complete. So when it's partial, we are going to have the salt wasting type. When it's complete, you're going to have the salt wasting type, and when it's partial, you're just going to have simple virilizing type. So what happens is that these are hormones that are in the cascade that helps in the production of cortisol or other steroid hormones within the adrenal gland. So when you have no production of this, what happens is that cortisol is going to become low, and when cortisol is low, the pituitary is going to be commanded by the hypothalamus to continue producing this ACTH, and ACTH is going to go and just cause the growth of this. So in different conditions or in different enzyme deficiencies, we shall have different precursors, hormone precursors remaining high. So some of these precursors are the ones that actually are going to be used by some of these precursors are going to be converted now into androgens. For example, when someone has a 21-hydroxylase deficiency and they are lacking that, they're going to have ACTH production, and ACTH is going to increase both production of androgens as well as the steroid precursors, corticosteroid precursors like 7-hydroxyprogesterone and androstenediol. But then these precursors are going to not continue because the enzyme important to convert them to cortisol is not there. That is the 21-hydroxylase. So they'll just continue into the bloodstream, and they will finally find their way into the fat tissue. As they reach the fat tissue, there is going to be a conversion of this into the sex hormones, and then we shall have virilization. So when we look at the salt wasting type, salt wasting type is going to be characterized by low cortisol, low aldosterone, because we have a deficiency in this 17-hydroxylase enzyme. And we're going to have increased androgens, as I've showed you why. And this is going to reduce visualization and shock as well as hyperkalemia. Then we have a hypovirilizing where we have a partial deficiency of this enzyme. Aldosterone will stay normal, but the rest of the things will be low. So this patient may not get into shock and may not get hyperkalemia, but they will have the virilization. Then we have the second most common enzyme deficiency, that's the 11-beta hydroxylase deficiency, where cortisol will be low, aldosterone will be low, but you shall have the DOC high. This is one of the precursors for formation of cortisol, and this is a prohypertensive precursor, so it's going to cause hypertension. And remember, those precursors of cortisol that remain are going to be converted in the periphery into the sex hormones that will cause virilization. Then we have 17-hydroxylase deficiency, where we have low cortisol and low androgens and increased DOC, and that is going to also lead to hypertension and sexual infantilism. Then we have beta HSD deficiency, and this is going to cause ambiguous genitalia, and the most severe form is the cholesterol deficiency, and this one is going to lead to all disruption of all steroid synthesis, and it's going to lead into fetal salt wasting syndrome that is going to be seen in phenotypic males, females, all those that are supposed to be females. So investigations you're going to do the basically check for these hormones. You're going to do analysis for the hormones. You can do electrolytes where you can see things like salt wasting. You can check for serum androgens and see are they high. You can do ACTH, it will be high. Then you can do genetic testing, and newborn screening is also done in very many countries. So the management is that you're going to give hydrocortisone, that's the steroid to suppress the ACTH axis. And you may need to give hydrocortisone, that is for the mineralocorticoids, for the salt wasting types. And then you may need to do the surgeries for the genital anomalies, because the children a lot of times are going to have ambiguous genitalia. Then lastly, we're going to look at the adrenocortical carcinoma, and this one is rare and has a bimodal distribution. It's found both in children as well as the elderly, and optionally we are going to have 50% of these tumors are going to be functionations, are going to produce enzymes. So the conditions that are associated with them have the Hormonal syndrome, that is p53 mutations, the main one, Beck-Widerman, as well as the Candy complex. And features of this is that we have a rapid Cushing's features, because the tumor is producing the steroid, the cortisol, as well as virilization. So whenever someone with rapid Cushing features or virilization, you want to check out for this. Or if they have feminization, then they will have an abdominal mass or pain, sometimes weight loss, anorexia, and nausea, and rapid progression that is more typical than an adenoma. Investigations, you want to do a hormone panel because you want to rule out any of the other things, any of cortisol, dihydroepiandrosterone, which will be high, androgens, aldosterone if we are hypertensive. Imagine most of the time you're going to see a large irregular mass that's greater than 6 centimeters. So whenever I say greater than 6 centimeter mass, you want to really question yourself about malignancy, necrosis, calcifications, invasions, heterogeneity, hemorrhage, and lymph nodes. These are all features on CT that you can see. Then when they do the MRI, there's a slow gadolinium washout, whereby when they use that contrast, it takes longer to wash out in areas of this. Then when you do pathology and you look at the mitotic index is going to be higher, there's capsular overcellular invasion, and then you want to screen for metastasis. So the management is going to be incomplete surgical resection, and that is the gold standard. You want to remove everything and block and associated. If the cancer has invaded anything around it, you want to go with that tone. Incision is not necessarily used. We have the subcostal and the abdominal, and then we can do debulking for isolated or recurrent disease where you can reduce some of it. Then we can use some drugs like mitoten. Mitoten is derived from DDT, which is an insecticide, and it's found to have adrenolytic properties. It cools the adrenal tissue. So for unresectable metastatic disease, you want to give adjuvant mitoten. Then you can use chemotherapy, that's the EDP, etoposide, doxorubicin, and cisplatin. Then you want to consider radiotherapy for local control. All these tumors are not, most of the time, they are not radio responsive. And then you want to do ketoconazole, metirapan, steroid hypersaturation. And then you want to do targeted molecular therapy. That is a version of video growth factor 1, tyrosine kinase 1, and IGF-2 inhibitors. So we have come to the end of this video, and we have looked at a lot of issues that are concerning the adrenal conditions that majorly are localized to the cortex, and most of these are going to be managed surgically. So check out other videos on the channel. Make sure that you check out next video about adrenal conditions, which will cover the adrenal medulla as well as the conditions associated with hypocortex, or where the cortex produces less than expected hormones. Thank you very much. My name is Benjamin. Don't forget to like, share, and subscribe to the channel.